Hi everyone, my name is Tiffany Jones, and today, as a part of Advanced Clinical Procedures, I will be presenting my periodontal assessment project. All right, here we see our patient, Joseph Klein. Joseph is a 43-year-old male. He has Down syndrome, or also is known as trisomy 21. When it comes to age, I know we said Joseph was 43, but for a 50-year-old patient with Down syndrome, the average IQ equates to about an 8 or 9-year-old. And for a 30-year-old patient, the average IQ equates to a 5.5-year-old. So maybe if we cut that in half, add a few years, with Joseph being 43, we could maybe say he has the IQ of a 7-year-old, but that varies greatly depending on the individual. Joseph is a Caucasian. He is a picky eater. Unlike most people, he likes fast food and sweets. He lives with his elderly parents, and his two older siblings do not live close by. They live in other states. He is accustomed to his routine and enjoys riding his bike, and he goes to his favorite hangouts, his favorite pizza place, and coffee shop. Alrighty, here you see Joseph has hypertension associated with cardiovascular disease. Cardiovascular disease is a very broad category that many things fall under. And patients with Down syndrome have a lot of cardiac complications throughout their lives. Joseph was born with atrioventricular septal defect. It's the most common defect seen in babies with Down syndrome. This results in a large opening in the center of the heart. Joseph had this repaired before he was 6 months of age, which is recommended, and it was corrected with surgery. Unfortunately, many years later, Joseph experienced another cardiac disorder called mitral valve prolapse. It's a residual defect associated with atrioventricular septal defect, and it's very common. And it occurs in more than half of adults with Down syndrome, even if they have had no other previous cardiac issues. So this is really important for the dental professional and any healthcare professional to be aware of. Many patients with Down syndrome, regardless of whether or not they have previous cardiac issues, should have a cardiologist screening them regularly to make sure that nothing is going on or developing. They're also at risk for developing valve dysfunctions, which could lead to cardiac heart failure. So Joseph had mitral valve prolapse, and he underwent a valve replacement, and he sees his cardiologist regularly. This is a red flag to us because with the mitral valve replacement, Joseph's cardiologist recommends a pre-med prior to treatment. Anyway, off topic. Back to the medications Joseph is prescribed for hypertension. He's prescribed two, metoprolol, and he takes the brand name Lipressor, which is recommended to be given initially at 50 milligrams, and then it's titrated until the proper dose is achieved in order to regulate the blood pressure. And Joseph takes this medication divided in 2 doses. So in the initial part of the day, he takes 150 milligrams, and that later on in the day, he takes an additional 150 milligrams to equal the 300 milligrams that is especially tailored to him. Special considerations when taking metoprolol are severe hypertension, and this is more so associated when you start compounding hypertensive medications on top of one another, which any cardiologist should be aware of and should be avoided. Contraindications associated with metoprolol are with NSAIDs, so he cannot take ibuprofen or Aleve. Acetaminophen should be avoided. Antidepressants should be avoided, and heartburn medications. Oral effects of medications, these are only due to the metoprolol. See, there's sore throat, sores and ulcers in his mouth, bleeding gums, xerostomia, and dysphagia, which is altered taste. Hydrochlorothiazide is also used. It's a diuretic, and Joseph takes 25 milligram tablet a day. He can also not have NSAIDs with hydrochlorothiazide. He should not drink alcohol as it can worsen the side effects and it can lead to impaired kidney function. Contraindications associated with hydrochlorothiazide are a hypersensitivity to sulfonamide drugs, diabetes, kidney and liver disease, glaucoma, and asthma. Some oral effects of his medications with hydrochlorothiazide are blue lips, bleeding gums, xerostomia, fruity breath, petechiae, swollen tongue, white lesions, a sore throat, and tenderness in his salivary glands. Here you see some overlap with sore throat and sores in his mouth, bleeding gums, and xerostomia. So those are definitely ones you want to be keyed into to watch out for. However, I don't have any medications associated with Down syndrome because they do not medicate patients with Down syndrome for Down syndrome. It's not a treatable disease as it is a genetic condition. So I'd just like to talk about maybe some things that you could see that are commonly associated with patients with Down syndrome, conditions in their mouths that you'd want to be aware of. Well, traditionally, patients with Down syndrome have premature eruption of their permanent teeth. Many teeth may be missing. They may not receive a permanent dentition. Their roots of their teeth could be shortened and they could be conical. The delayed eruption of permanent teeth is associated with a smaller maxilla and a prognathic mandible, which a prognathic mandible can cause a prognathic relationship between the maxilla and the mandible. This can contribute to Joseph being a mouth breather, and due to the fact that patients with Down syndrome also have airway problems, this could also contribute to Joseph being a mouth breather. Patients with Down syndrome have a high vaulted palate. This does not give their tongue a lot of room in their mouth, which may also be a reason why they have an open bite. Patients with Down syndrome have a very high risk of developing periodontal disease. They're not as common as normal patients as far as caries development. It almost seems like they have something that prevents them from developing caries at a normal rate. However, with patients with Down syndrome liking a cariogenic diet and perhaps taking medications that cause xerostomia, Joseph is at a normal increased risk for developing caries. Also, patients with Down syndrome develop cracks and fissures in their tongue, which trap bacteria and can cause halitosis. All right. Moving on to the periodontal assessment, Joseph has ADA case type 4, generalized severe periodontitis. This is evident. Joseph has greater than 5 millimeter clinical attachment loss, generalized throughout his dentition, and his pocket depth generalized 6 millimeters and above. He's got a lot of recession throughout his dentition, and as you already see, he's already missing a lot of teeth, either from his severity of periodontitis or in the anterior regions. He could have been prone to a fall, which could have contributed to a loss of teeth. You also see he's got 2 teeth that are mobile, class 2 and class 3 mobility. He has a high percentage and probability of losing those teeth, and he's got furcation involvement on the mandible in teeth number 19 and 30. This is a class 2 furcation seen. He also has generalized bleeding. He came into the practice with necrotized ulcerative periodontitis, and his tissue is very sensitive and inflamed. And you definitely see that it's indicative in how much bleeding he has. His AAP, periodontal classification, which we were able to make with the help of his health history, we have determined Joseph to have non-plaque induced gingivitis caused by his genetic condition, Down syndrome. He has generalized chronic periodontitis that is case type. It's very severe with more than 5 millimeters of clinical attachment loss. He also has a genetic disorder. He has Down syndrome, and Down syndrome and periodontitis go hand in hand. He also presented with necrotized ulcerative periodontitis, and due to his genetic deformities, he has short roots, so we can see on his radiographs, and he could have occlusal trauma due to malocclusion of his teeth. His ADA periodontal case type, he's class 4 severe periodontitis with more than 30%. It's generalized. His probing depths are 6 millimeters and above. He's got generalized bleeding, and he also has recession. He has furcation class 2 and 3 on tooth number 19 and tooth number 30, and mobility 2 and 3 is seen on tooth number 5 and tooth number 13. On his radiographs, you see alveolar bone loss, 5 millimeters and above. You see horizontal and vertical bone loss, 5 millimeters of clinical attachment loss. You see furcations visible on the radiographs, and he has a crown to root ratio of 2:1, and you can see more than 30% radiographic bone loss throughout his dentition. His gingival description, he presents with gingival color generalized moderate dark pink to red. It involves the free, attached, and papillary gingiva. The contour presents as generalized, severe, rolled and rounded margins with clefting and recession into the attached gingiva, and generalized bulbous and punched out papilla. The consistency presents as generalized severe, soft, spongy gingiva that involves both the free and attached gingiva. Surface texture presents as generalized moderate, shiny gingiva with fibrotic tissue and a loss of stippling. Here are the assessment statements, all laid out in a nice convenient table. Here you can also see his radiograph and one picture of his mouth. Here is his radiographic image. Here you see I chose a pano. Patients with Down syndrome might be a little bit better able to handle one x-ray, and this one lets us get a full picture of all of his teeth and his bone loss. Here you can see vertical bone loss, a possible class 2 mobility, and possible class 3 mobility. This furcation could be a class 2 or 3. He's got horizontal bone loss, which resulted in 5 millimeters and above clinical attachment loss. You can see a clear crown to root ratio, a 2:1 ratio with more than 30% bone loss. Another common occurrence in patients with Down syndrome is osteoporosis of the bone, and here you can see one area where the bone might be starting to osteoporose. Here is the first gingival image. Here you see fibrotic tissue, spongy gingiva, you see some white patches, which is associated with metoprolol and hydrochlorothiazide. His gingiva presents as erythematous. He's got ulcerated margins, and also patients with Down syndrome are prone to have high frenal attachments, which could attribute to tooth loss or recession of the gingiva. The next gingival image also, it shows recessed gingiva, cratered papilla, definitely erythematous margins, white patches on the picture to the right. The margins are rounded, punched out papilla. You can see a loss of stippling and also high frenal attachment right there between 24 and 25 in the picture to the left. This image shows us kind of something different. You see that hyperplastic, that fibrotic, swollen tissue, clefting marginal gingiva, festooned margins. Gingiva looks like it's probably really soft and swollen. Ulcerated margins, loss of stippling. This image also shows a loss of stippling, punched out papilla, lots of recession. You see a lot of root on these teeth. Very shiny, free gingiva, and it has that bright red color. You see bulbous papilla. The dental hygiene diagnosis, ADA case type 4, severe periodontitis, listing some of our outcomes that we expect along with our prognosis. I rated Joseph's condition as a questionable to hopeless prognosis. My rationale being inadequate attachment of many teeth, with many already extracted due to mobility and recurrent infection. And we see this currently in his examination. He also has shortened roots in the anterior due to his congenital defect, Down syndrome. Long-term goals, we'd like to eliminate the risk for caries due to xerostomia and stabilization of the bone loss, hoping to save the teeth he still has. We want to put him on a frequent recall to check on his prognosis and his progress with home care and his periodontal maintenance cleanings. In the short term, we need to remove his mobile teeth to eliminate the nidus for infection. We need to educate him on adequate home care so he can remove the biofilm daily. And we need to reverse the necrotizing ulcerative periodontitis to eliminate that and get him on track with better nutrition to keep it at bay. At home, he's going to use a home fluoride toothpaste and a night tray with fluoride in it. He can also use a night guard. Due to his occlusal relationship, undue strain can be placed on certain teeth, and a night guard can help rid any residual effects of that. And we might also want to look into sealants to prevent decay if the xerostomia cannot be remedied. Here you see some of his modifiable risk factors. We'd like him to cut down on sweets. He can sip on water throughout the day, adequate removal of biofilm, of course. So he can use supplements to help get his blood pressure under control, and he can use fluoride to keep his teeth nice and strong. Some non-modifiable risk factors Joseph has. He has congenital heart defects with a mitral valve replacement associated with Down syndrome, and he has acquired hypertension. Moving on to his treatment plan. We're treating Joseph as a current patient. So he'd come in, have a limited oral exam, problem focused due to his necrotizing ulcerative periodontitis. And he'd have a comprehensive periodontal exam to evaluate bone levels. We do a full mouth probe on that exam. We'd also like to do a preliminary debridement. And then he's also going to be in for 4 quads of scaling and root planing. We'd also like to deliver antimicrobials subgingivally to kind of help irrigate and clean out that infection he has. Of course, we're going to put a topical fluoride, and he will have a home fluoride as well. And I think for Joseph, it's very important that we do have thorough oral hygiene instructions at every appointment. And, from one appointment to the next, you can see where he is gaining more knowledge and where you might have to put a little bit more education and time into play. And of course, we'd also like to look into placing some sealants as we see necessary. Here is his treatment plan flow chart. He presents with necrotized ulcerative periodontitis, painful gingiva, heavy biofilm, and heavy calculus. So we'd start by doing a limited periodontal exam, problem focused due to the necrotized ulcerative periodontitis. After the exam, unfortunately, we'd have to stop because Joseph needs to pre-med. So he would take his pre-med, or maybe he would come in already pre-medicated because we know that he has to based on his health history. So if he has pre-medicated already, we can do his debridement. And after that, he can go home. We give him prescription Paradex to help get rid of that infection and clear him up and kind of get rid of the bleeding, keep that at bay so that on his next appointment, we can start the scaling and root planing procedure. So he'd come in on the next day, also having pre-medicated, and we would do the comprehensive periodontal exam where probing would be done. We do his SRP on the upper right. In this appointment, we can also do gingival irrigation and his first training in preventative care. On a subsequent appointment, we would come in, bring him back for another scaling and root planing on the upper left. Again, you're going to irrigate, and we also administer ClinPro 5000. The next appointment, we bring him in to SRP the lower left. We're going to irrigate again, and we'll determine his need for sealants. On his last SRP on the lower right, we're going to irrigate, and we're going to place antimicrobials, Arestin or Periochip, in the areas that we deem necessary. As far as instrument selection, we would select standard after 5 and mini 5 Gracies, both standard and rigid. And our rationale for this is that they're finishing curettes for light to moderate calculus and an extended shank for reaching into deep pockets. The scalars we would select are the Nevi 1, 3, and 4, the Barnhart curette, and the Diamond Tech, just to name a few. The Diamond Tech is great for scaling furcations, and we know Joseph has 2. And the rest are great for moderate supragingival calculus removal. The ultrasonic inserts we like to select are, besides the slim lines which are pictured in the graph, we'd also like to select right and left inserts, the beaver tail for heavy supragingival calculus, and the Powerline 1000 and 100 inserts. These are for heavy, tenacious supra and subgingival calculus removal. All right, there's Joseph, and we're getting ready for his home care recommendations. Some of Joseph's home care recommendations are prescription dental aids such as chlorhexidine gluconate rinse, otherwise known as Paradex, ClinPro 5000 toothpaste, fluoride trays containing 2% sodium fluoride that he can use as a foam and put it in a fluoride tray and wear overnight or even in his night guard. Some over-the-counter dental aids we recommend are floss picks, makes it easy for him to hold and to adapt to his teeth, or floss. Regular floss can be better used in a floss holder so he can reach the posterior teeth and way back in his mouth. A tongue cleaner is also ideal for someone with Down syndrome and Joseph because they develop deep cracks and fissures in their tongue, and that can lead to just bacterial overgrowth on their tongue, which can lead to halitosis. As far as toothbrushing techniques, I recommend phones. Going back to what we were saying about Joseph's mental age, and it equated to about the age of a 7-year-old, I think that the phone's method would really help to ensure that he's reaching every single surface on his teeth, and I don't believe that something like a bass would really benefit him. We'd also recommend the use of a power toothbrush, soft bristles recommended. And we're going to make sure that adequate time is spent on each of the teeth, all sides of the teeth, and that we're going over this at every single appointment with Joseph. The toothpaste we're recommending is ClinPro 5000. You only use a pea-size amount, and we make sure that he spits out the excess. And we want to recommend to him and his caregiver that he does not rinse after using ClinPro 5000. Also, if the patient with Down syndrome has trouble expectorating the product, or if the caregiver is unsure whether more is getting swallowed than spit out, and of course we don't recommend swallowing these products in excess when it comes to Paradex and ClinPro 5000, the caregiver can just take the Paradex and dip a toothbrush in it and apply it to the teeth almost like a varnish, just over the teeth. It still has those same added benefits, but we can ensure that the patient isn't doing any excess harm by swallowing. The same thing can be done with the ClinPro 5000. It could just be used almost like a varnish and just rubbed onto the teeth, and the residual effects of the fluoride can stay on the teeth. We already went over this briefly. Floss and floss aids. You can use floss picks or floss with the use of a floss holder. Interdental aids, because the teeth of a person with Down syndrome can either come in later or they are smaller. They have larger spaces in between the teeth, which makes access to the interdental areas relatively easy, but in order to better clean them, an interdental brush can be used. Mouth rinses, chlorhexidine as well. Swish for 30 seconds. This is really beneficial during the SRP to keep the bleeding at bay and help clean up the infection before and during the SRP. The fluoride here, again, we have 2% sodium fluoride foam. You can use it in a tray, administer it to the patient to use every night. due to the xerostomia caused by the medication, the beta blocker he's taking, metoprolol, and mouth breathing associated with Down syndrome, at-home fluoride is really beneficial for the health of Joseph's mouth and to decrease his risk for caries. Products to avoid, definitely while Joseph is still active with the necrotized ulcerative periodontitis, we want to make sure he avoids Listerine as it could just cause added irritation to his mouth. Oh, here we are at Joseph's nutritional analysis. Joseph has hypertension, high blood pressure, has no symptoms, but it can lead to serious health conditions or death. Due to the risk of hyperkalemia while taking metoprolol, patients are advised to omit foods high in potassium, like bananas, potatoes, prunes, raisins, artichokes, acorn squash, spinach, and almonds. Some of these things you may not realize they have potassium, as bananas is the cardinal one that we seem to think about. His condition, Down syndrome, is the most common genetic disorder in live births experienced in the U.S. It happens in 1 to 700 live births, in fact. Down syndrome affects every organ in the body and has negative implications for a healthy lifestyle. A balanced diet consisting of lean meats, fruits, and vegetables with whole grains and low-fat dairy will not only help patients with Down syndrome stay healthy, it will also help maintain a healthy blood pressure. Some stuff to add to the diet: nuts like pistachios and fresh berries, salmon, which is a fish that is filled with omega-3s, fiber-rich foods, leafy greens like arugula and spinach, oatmeal, and dark chocolate. We want to omit frozen foods, frozen pizzas, pickles, powdered potatoes and rice, those high sodium deli meats, canned soups, canned tomatoes they say to avoid, and bananas. Here is a weird one. Bananas and hypertension can lead to hyperkalemia, so they say take them out. However, the hydrochlorothiazide can lead to hypokalemia, so they recommend bananas. This is like a touch and go subject, and I think when you start to get into medications like this, you need to talk to a nutritionalist and to the patient's cardiologist to see how their potassium level is and whether they need to take potassium in or if they need to excrete potassium. And if it maybe comes to changing the medication to get on a puny diuretic to kind of help better control the potassium, maybe that's something that the physician needs to revisit. Things to avoid. Of course, you want to avoid alcohol. Coffee. Fennel and aloe are contraindicated with hydrochlorothiazide, as aloe increases the risk for hypokalemia. Apple cider vinegar, licorice, artichokes, garlic should be avoided. And you see, you have foods high in potassium should be avoided. Supplements, potassium. Strange. Do we add it? Do we take it away? Magnesium. CoQ10 is seen to reduce hypertension, so it helps lower your blood pressure. Plus, it has an added benefit of safeguarding patients and perhaps plays a role in Alzheimer's development, since patients with Down syndrome are at an increased rate of developing Alzheimer's 10 to 20 years earlier than similarly aged patients without Down syndrome. It could be a very important supplement to add into their daily routine. Vitamin E is also essential, and iron. All right. As you are looking at my assignment grading rubric, I'm just going to remind you of a few helpful tidbits when it comes to setting appointments for a patient with Down syndrome. Every patient with Down syndrome most likely is going to come in with a caregiver, whether this be a family member or someone hired on to help and take care of them. And they know best how to deal with the everyday ins and outs of things associated with this patient. So you can coordinate with this caregiver effective techniques that they use to manage the patient and their behavior. However, most patients with Down syndrome are warm and friendly, and they're well behaved. Initially, they may come off as uncooperative, but I think the more you're able to warm up to them and they're able to warm up to you and start to trust you as their healthcare provider, the easier these appointments are going to be. Some things to keep in mind: early appointments are probably ideal. Morning is maybe when the patient is at their best. They've just eaten breakfast and they're getting their day going. They're excited to begin their day, and it could be best to have them in early in the morning. You want to involve everyone in the office, from the receptionist to, people they might pass by. Definitely let your coworkers know of the patient you have coming in, and maybe they can just take a little bit of time out of their day to extend, a friendly hello and a warm greeting. And then more importantly, this needs to be consistent every time they come in. And of course, we know Joseph is going for 4 quads of scaling and root planing. So in those 4 appointments, you want to make sure that things happen the same way they did before. You seat the patient, you start with the vitals. They're really big into routines, and this doesn't, mean that it has to end at the dental office. The dental office is big into routines and how you get things done, and that's how it should be in order to deal with a patient with Down syndrome. Well, thank you for listening. I hope you've learned something today about Joseph and his comorbid hypertension and Down syndrome diagnoses. Thank you for listening. Bye.